I also know a lot of organizations are struggling with enterprise-wide deployments and addressing the change management. That doesn't seem to be an issue here. Or maybe you guys are so good through the academy that you were able to address these issues.
I really can't say enough positive things about our digital academy team. When I look at all of the implementations, we probably did 100 implementations in 2025.
Ambient was only one of them. Yeah.
Is this just for physicians, or are there opportunities for other workers throughout the organization to utilize ambient listening?
Greg, that's a great question. You're not the first to ask it. We've focused on our physicians and our advanced practice clinicians, but we've actually more recently been also working with our clinicians in the behavioral health space, our licensed social workers and therapists on, the tremendous documentation burden that they have and the potential opportunities there. I think the use cases are endless, and it's on the burden is also on us to be just as thoughtful as we're approaching scaling in these new areas as we have been to date. But I do think there is opportunity for sure, and we're trying to figure it out.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malcury. I'm the Managing Director at Lighthouse Health Tech Advisors. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Today, we're talking about ambient listening, not the hype, not the demo, but the part that shows up in day-to-day care with real clinicians doing real work. Across the country, physicians are spending 1 to 2 hours after hours finishing documentation. That's time pulled from patients, time taken from family, and time that should be allocated to rest. Ambient listening is not a magic fix. It only works when organizations are ready to change workflows, daily routines that shape care. If that work stalls, you get documentation, but you don't get transformation. And that's why Sutter Health's early results in ambient listening stand out. Clinicians are charting less after hours, burnout is declining, and 93% of physicians who are using the tool today indicate that they devote more time with patients during their visits. Now, Sutter Health has made ambient listening a system priority. This has helped reduce variation, cleaned up EHR debt, and opened the opportunity for new capacity across the enterprise. The people leading this work at Sutter are not talking about ideas. They're actually delivering results. So today, we're fortunate to have two Sutter Health leaders who are driving the ambient listening work forward. We have Dr. Veena Jones, Chief Medical Informatics Officer, who's leading transformation at Sutter Health. And we have Stephanie Driscoll, the VP of Clinical Applications, overseeing EHR optimization and Epic integration. Now, before we dive into today's discussion, I want to recognize our valued sponsor who made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. So with that, why don't we get started? Veena, when did physicians start telling you that ambient listening was taking pressure off their day? And how are those comments showing up?
Yeah, thanks, Greg. Thanks for having us here today. It's a pleasure to get to have this conversation. I think it was really, really early on. We are over 1.5 years into our journey with our implementation of ambient listening. And from those very first few days with our initial clinicians, I think we heard stories of first delight and very soon just transformative experiences. I think the most profound are probably the messages of gratitude that both Stephanie and I have received over email, via text, even some phone calls, stops in the hallway around, this is really changed my life. I wasn't sure. I didn't know, but I gave it a try. And wow, it's saving me so much time. So I think it started right from the beginning. And, we're going to talk more about this, but we've scaled pretty significantly across our enterprise. And every month when we bring a new wave of users on, we hear similar stories.
Give me an idea of the scope of the deployment. When we talk about enterprise-wide, what does that mean? Just to give us an idea of how widely you've deployed it. Because I think you guys are 26 hospitals and hundreds of different ambulatory environments, but just give us an idea of the scope.
Sure. And before I do that, Stephanie, were you going to jump in and say something?
I really just wanted to add to what Veena said. I think, you spend 20 years implementing Epic, clinical systems, all the different tools in the physician space. And in my tenure, my whole career, this was by far the most overwhelmingly positive change that we have ever made in the clinician space. I mean, I think, Veena, we can't emphasize enough the amount of gratitude from the physicians, the notes of the reduction in cognitive burden. Just, again, by far the most positive implementation, positive tool that I've implemented to date.
Yeah, and I guess to riff off of that for a second, I mean, as an informaticist and for Stephanie, in all the years that she's worked, I think typically when we think about implementing technology, it's really having to push, right? To push past the discomfort and the change. And sometimes that is real. I mean, change is really hard, right? But this is a technology that our clinicians have really pulled. They've wanted, they've been knocking on our doors asking for more. And so, Greg, to answer your question about, what does our scale look like and where have we implemented, based on that pull, that really strong desire from our clinicians to use it and have access to it. At the beginning of this year, so I guess about a year ago, we opened up essentially what we called an intake or enrollment process. We started with all ambulatory clinicians, both physicians and advanced practice clinicians across our enterprise. And we began just onboarding them in monthly waves. So anybody who was interested could fill out a form saying they wanted it, and then we would turn that around and bring them on board. In March, we became the first customer, both for our ambient vendor and for our EHR vendor, Epic. We were the first to implement a fully EHR integrated version in the inpatient setting. And so after launching that, also a few months ago opened up an intake process for every clinical setting across our enterprise. Any physician and advanced practice clinician working in any clinical setting across our enterprise can request a license and be onboarded. We are now at over about 3,100 individuals who are licensed to use a bridge, and that number is steadily increasing.
Wow. I just want to tee off of what you just said about the EHR because it's very significant. Everyone always complains, is it integrated with the EHR? Obviously it is. So Stephanie, within the Epic EHR, what did you do to simplify so ambient listening could easily flow into the chart without requiring additional work?
Greg, I think the question really leads to one of the cornerstones of this entire implementation, which is really around Sutter, outside of our AI and ambient projects, is really on a journey to optimize and standardize and really streamline our Epic foundation and its workflows. And so what that looks like in the background, like the foundation of Epic, is working to consolidate service areas, reducing our specialty profiles. So going from having hundreds of different specialty profiles across the organization to like more of one standardized profile for each of the specialties, cleanup of our physician preference list, standardization across some of our note and scheduling templates, really just around building that optimized foundation for us to be able to not only adapt ambient, but how do we prepare Sutter to be able to quickly adopt all of the AI that's coming. And it's hard to do that when you have folks working with like disparate workflows clinic to clinic. And so a big focus has been on how do we clean some of this up to be able to adopt the AI faster.
Wow, that's really impressive. So the change management was pretty significant, right? You have different fiefdoms within the global organization, and getting everybody on the same page, at least in many other organizations, could be quite challenging.
I imagine it's challenging in all of the organizations. Sutter specifically, we really looked at, we have a variety of different medical groups, many of them focused in different regional settings. And so I would say, yes, the change management lift is not something that I feel like you should underestimate. I think we worked on a lot of tools pre-implementation and our ongoing training and our support structure within the organization to really help us positively affect these changes across the organization. But I feel like for Sutter specifically, a lot of that foundational work was a big lift.
I was like, can you just pivot a little bit into some of the specifics of what you did to the EHR foundational model that made it so you could integrate it so cleanly into the Epic EHR?
I think some of the biggest changes are really around preparing for future functionality. So I mentioned note templates, but another big area of focus for us has been around like the preference list and orders optimization. So as we, prepare for the future of ambient, being able to queue up orders for the physicians, making sure that we're all working off that same list of orders, preference list to be able to prepare the AI to queue that up for the physician.
Okay. Maybe you could also talk about some of the governance issues, right? As it relates to safety, accuracy, daily care. What are some of the issues that you've actually kind of put in place or been able to resolve, maybe with more of an extended team? Because it sounds like a real enterprise-wide commitment.
Yeah, and actually, Greg, before I dive into that, I think the other piece that I would just add to what Stephanie had commented on was
Yeah.
another part of our strategy around scaling ambient was really focused upon how it would best integrate into our clinicians' workflows. So when we first launched Ambient, we actually launched it for 100 clinicians using a third-party application, so like the vendor application. So a clinician would walk into the room with the patient, they would have to open this separate application that would record the conversation, create a transcript, and then they would have to use smart phrases to pull that generated note content into Epic. Not ideal, right? That doesn't fit as seamlessly into the clinical workflow. But soon after our pilot, a full EHR integrated version was released where a clinician could actually use the native Epic mobile application, Haiku, and use Ambient directly inside of Epic. So all within the Epic infrastructure, our clinicians could leverage and use Ambient. And so we actually waited for that functionality, tested it, implemented it, optimized it. And it wasn't until we felt confident that that end-to-end workflow was seamless that we really opened up the floodgates and scaled more broadly. So I do want to emphasize that in addition to all of the foundational work that we just spoke about, I think that critical workflow integration decision made a really big difference for us. And we did the same. We waited again before we scaled across additional clinical settings like the emergency department and inpatient. We really felt that that workflow integration was the secret sauce, right? That made it easiest to use for our clinicians. So
Maybe you can take into a little more detail. When you look at primary care versus urgent care or any of the specialties, are there differences in the workflows that you had to take into consideration? Because you are dealing with a diverse set of end users.
Yeah, absolutely. And, we were very strategic when we first launched in not focusing on just one specialty. We really wanted to understand how is it used across different clinical settings and by different clinical users, because we didn't want to make any assumptions. And I think what we found is, to your question about primary care and urgent care, I think definitely some of the strongest outcomes have been in those specialties. So our primary care clinicians, our urgent care, our emergency department clinicians, once we opened it up in those spaces, I think the comments, the feedback has been pretty resounding. Our overall net promoter score across our users in our more recent data was as high as 87. So our clinicians absolutely like using it and would recommend it to others, but it's not perfect yet. And there are still some clinical workflows where we continue to push on our ambient vendor and continue to work with our clinicians on how we can collaborate to improve the functionality and the workflow integration.
I actually have had some visits actually at Stanford, your local competitor, but they asked me up front, hey, do you mind if I use ambient listening? Here's what it's all about.
Mhm.
The look of glee on their face, because I knew this podcast was coming up, I go, can you show me how it works? Right.
Yeah.
And it was really fascinating. I was very intrigued by it, but he
Mhm.
saw it as a net positive and not as
Mhm.
another added burden on him during the visit. I'm sorry, Stephanie, I interrupted you.
No, it's okay. I was going to just add, I think we've also received a lot of positive feedback from our patients. I think there
Mhm.
was kind of this initial thought around how would patients receive the idea of the AI ambient technology. And a lot of the feedback has really been overwhelmingly positive from our patients as well. And the one thing that I would add that I think was interesting as we thought through the governance and the approach for our implementation was around the selection of the piloteers and making sure,
Mhm.
to Veena's point, we had that variation across specialty. We had variation across our different geographic locations. And then I think for our initial piloteers, we really focused on our physicians and our informatics group who were more tech savvy. And I
Mhm.
think one of the challenges we saw, for example, with a bridge originally not being integrated directly or inside Epic was also around having our physician piloteers update their mobile phones with the right
Yeah.
security protocols, multi-factor authentication, an added step that, makes the barrier to entry a little bit harder. And so we really looked at that and took that feedback and said, you know what, we should really wait a little bit longer, continue to assess the tool, but then really wait to scale more broadly until we had that direct Haiku Canto Epic component. And I think that was hard in a couple of ways
Mhm.
because by the time we had our 100 or so piloteers, the word was out there. So I think Veena and I probably at least I don't know, 10 times a day would receive emails or texts or phone calls from medical group presidents and folks who would say, hey, I have this physician. I've heard about a bridge. I hear it's amazing. This physician spends an inordinate amount of time in their notes, and we really want them to have the tool. Can you put this physician at the top of the list? Can we give them the tool? And so Veena and I were really, I think, thoughtful in that. And we really had to say, hey, we think this physician would be a great candidate for Inside, and that's coming in a month. So there's kind of an interesting
Yeah.
mix of people find out the tool is out there, they really want it. We piloted with our tech savvy users, which I very much feel like was the right thing to do. But then you also have that need on the physician side for folks that really are struggling in the documentation space and want the tool. And so I think that's just a good point of awareness of once the word gets out there and everybody wants it, it's still important to be really thoughtful about, is it going to be the right tool for that subset of physicians?
We'll tell you when I was this is just last week. It was the way he presented it. It was very non-threatening. He was so excited about it. Well, I'm more technology savvy, so I was a yes. That sounds great. But his presentation made all the difference in the world, which kind of leads me to my next question, either Stephanie or Veena, about the training process, right? Is this a standard of care now? How did you introduce it to them to get them on board? Because obviously, a lot of these guys are under pressure to see a lot of patients, right? How did you
Mhm.
get them to be accepting of this? And obviously, you've been successful because I guess the majority of your physicians are using it.
Yeah,
I would
maybe I'll
say,
start and then
go ahead,
Stephanie
Veena.
will jump into the academy. Sorry, I was, I guess I would say we learned a lot, both from our initial pilot group and then, as we've scaled around the best ways to train and optimize use. But also to speak more directly to your question about how did we get our clinicians to accept it and to use it, I will really just have to emphasize again, like, it was a pull. I think, the way that we started our implementation with our tech savvy clinicians and informaticists, I think the general vibe and the general conversation has really not been around how do we get our clinicians to accept it. I think it's been around how do we get it out there fast enough into the hands of our clinicians who want it, and how do we get it into their hands and quickly and efficiently teach them how they can use it. And so that's where I think our training and education has really evolved over time. Our first group, we actually launched with hour-long mandatory Zoom sessions where partnered with the vendor, we walked them through like slides on how to use it. And we got tons of feedback on, hey, that's not a great way to teach us how to use something. It's pretty easy to use. Like, just give us a little material and we can go at it. And so Stephanie can talk a little bit about our Sutter Health Digital Academy and how we've leveraged really putting a team in place for whom one of their focus areas has been around our ambient and ambient listening and training and optimization.
Yeah, I would say Sutter has a somewhat unique model in that, like, our enterprise learning and our support team, Veena reference called our digital academy team, is really like the effector arm of change within our organization. So this team is really on site. They're rounding at the clinics daily. They're rounding in the hospital facilities. They partner so closely with Veena's team and with our local physician informatics within their regions. So they're really at the elbow with the end users throughout the week. And they work on all of our communication, education updates. Actually, prior to the use of ambient listening, this team also helped our physicians with adoption of tools like voice to text dictation. So they would help the physicians set that up. They help the physicians configure smart phrases. So it was really just a natural built-in support system that we had when we implemented a bridge. But I think what Veena hit on is really accurate. I would say our training and education approach was really an iterative process. We ultimately ended with more of like a self-selection onboarding e-learning that we have within our learning management solution. But I wouldn't underplay the amount of effort that it took to get provisioning to a place that we were happy with it. Like, we really wanted it to be like a self-enrollment and then be able to just automate a lot of the provisioning on the background. And I think that also uncovered some governance related questions around who all were we going to open up the selection to? How are we going to provision? Were we going to make it available to all of our affiliates, our Epic Community Connect practices? Again, also using our Epic solution, but very much interested in all the AI tools that are coming. So I wouldn't underplay some of the provisioning work. Like, it's not just about getting the e-learning and the content right and having the support in place, but it's really about that like zero friction ability to sign up, provision enrolled, and then hit the ground running with that support system at the elbow to help optimize it.
Now, just
And
out of
we're
curiosity,
still Oh, sorry, Greg. I was just going to add that we're still iterating on that. I think like we are still working on how we can make that as smooth and frictionless as possible. So the work has not stopped, even though we're more than a year and a half into this journey and have thousands of people using it.
wow, slightly different question. Does the ambient listening, does it address both the billing documentation and the clinical documentation?
I would say it addresses some of the cornerstones in the content of the note to help support the coding on the back end. So I would say when we went through and did the implementation, we partnered closely with our coding team They participated in the testing. We really wanted to ensure that the output of the note would still support accurate levels of coding. So I think in that regard, it does support some of that, like the billing documentation, but not at the point yet where we're headed, where it would like recommend that E&M billing code. So I think that's future functionality that we're looking to take advantage of. And the one other thing I would add to, Greg, is I think on the front end, we also wanted to make sure we were cognizant of like our HCC capture for patients. So by, placing ambient, were we going to negatively impact our HCC capture rates? So I think that was another area where we looked at thoughtfully when we did testing, prior to the idea of diagnosis aware nodes and ambient. That was another area that we were really thoughtful about during the implementation of, how does this impact billing downstream, even if it's not yet at the point where it's recommending how to bill.
100%. Now, I do know that Epic has its own coding wizards as well for E&M coding. So maybe that's part of just a bigger picture of how do we have a full circle. So by the time it goes over the wall to billing, clinical doc and billing documentation are totally aligned in order to write code. I think that's the right term now, right? Write coding?
Greg, I don't know if you did this intentionally, but I really love it's very much true. It is the wizard. And I felt like you had a nice like wand motion going there, like the Epic E&M wizard. But yes, I think that was a huge focus for Veena and I, was making sure that we were going to be able to support the billing. And I think a lot of the data that we saw in the back end also supported that we were seeing like appropriate coding and better billing as a result of the ambient listening.
Well, if I could be wrong, but in many organizations, 50% of ambulatory claims are denied. And so this would actually help increase revenue capture.
Yeah, I mean, I think that's the goal. And as we're having conversations with our ambient vendor around their rev cycle roadmaps and where they're going, I think there is a lot more potential and opportunity, to unlock and that we're interested in partnering on. So I think ambient and the documentation in the note is really the beginning. And Stephanie had alluded to the fact that we've just launched a pilot with some of our early adopters, our clinical champions, to test out medication order entry, where, based on the conversation, the appropriate medications are teed up in the chart and made available for a clinician to sign. So I think that's definitely an area that we're focused on and working with our vendor to improve clinical workflows around.
Love this. Sounds like this is a foundational part of the technology stack, right? That affects all aspects of clinical encounters and also the whole billing aspect, which is what enables you to keep your doors open. Veena, let me ask you a question about time. Where's the time saving? Is it after hours or is it during the visit or both?
I would say both.
Yeah.
I'll let Veena take it. Veena has like the most details, but I would say both. We've seen reduction in time spent in notes and reduction in pajama time.
Yep, exactly. We've seen it across the board. And honestly, the reasons for the variation are very clinician dependent, right? We have some clinicians that, have sent me notes and responded to our surveys and been interviewed and have said, I'm going home 2 hours earlier simply because that burden of remembering everything and documenting while I'm with the patient, that's gone, right? But I'm choosing to have spend less time in notes during the visit and go home earlier. But my pajama time is the same because I get to spend those 2 hours with my family and log in later to finish my documentation. We've got other clinicians.
It's funny you should say that because I live next door to a Sutter physician. And I was wondering why he was so happy lately getting home early.
That could very well be the reason. I'd be curious to know. But then we have other clinicians that are like, no, when I want to be done my work like before I leave the office. And for those clinicians, we're seeing tremendous amounts of pajama time savings. And so when we look across the gamut, I completely agree with Stephanie. We're seeing both. Overall, we're seeing time in notes, an EHR signal, an EPIC signal metric. That signal is physician data around, or really clinician data around how they're spending their time in the EHR. And we've seen significant reduction in time in notes. We've also seen across the board, when you look at our aggregated data, pajama time saved, which is work outside of work, time spent after work in the EHR.
That's part of your operational dashboard, right? Of one of the key metrics you're looking at right now. That's impressive.
Yeah.
Definitely. As more teams adopt these technologies, how do you keep the workflow simple so clinicians don't slip back into old routines?
I think that workflow is one of our guiding principles behind responsible AI use. So even when we evaluate new tools and products at a governance level, we really bring it down to like, what is the workflow, the optimal workflow that's going to support the change that we are looking to gain with the AI tool. And I think we have a really specific focus too on, is there an intervention that we expect from our clinicians or staff to really achieve the results of the AI? And so I would say like the focus on workflow, like Veena mentioned earlier, even if it means like delaying the scale a month to have like a piece of critical functionality that's going to streamline that workflow, we believe it's worth it. If it doesn't feel like the AI is embedded and kind of that trusted partner in the workflow, it's not going to be as widely adopted. And so I think I bring it back to the workflow. I think that is one of our driving guiding principles behind AI. We heavily look at that when we explore other AI tools, and not just AI tools, but also what are the use cases for the tools, and what's the use case that we start with the tool. So when we just evaluated ADAC, like a imaging AI tool, evaluated, I don't know, Veena, 4 or 5 use cases that we will plan to scale, but what is the workflow that we know that we can streamline and operationalize now? And let's start there and then evaluate future use cases after that.
Wow, I love it. Veena, what does the next year look like for your physicians? And where do you see Ambient Listening making the biggest difference as it grows? So you can go on a soapbox, you can give us your vision of where you are today and what's realistic, maybe over the next 12 to 18 months.
Yeah, I mean, I love these like, can you predict the future questions? Because if you asked me 2 years ago where I thought we would be, I think I would have been off by a lot, right? I mean, now feels like ambient listening for documentation is almost table stakes at this point. And so I think the question is, how are we as users going to differentiate ourselves? I think that's definitely been a strong focus here at Sutter. We have a new chief AI officer, Dr. Ashley Beasy, who's part of our group and spends a lot of time really thinking about our AI strategy, as a whole, as we look to be bold and move quickly. When thinking specifically about ambient, I mentioned this a little bit earlier, but I do still think there are many areas where we've yet to unlock some of the potential for many of our procedural specialists or surgeons, even our medical subspecialists. There are a lot of nuances to the patient care that they provide where ambient is not yet optimized to help them. Whether it's a joint injection for an orthopedic surgeon who is running a super busy clinic and would love to just be able to speak out loud as they go and have all the documentation taken care of. I still think there is a lot of room for improvement. And then on the ordering side, Stephanie's comment about holding until we get it right, I think we're living that right now with ambient ordering. So, we've launched a pilot. It's somewhat limited. We do think there's some opportunity for development from our vendor. And I think we're really wrestling right now with that decision again on, do we hold, do we scale? And I think we're leaning towards holding for a little while as we want that functionality to really be optimized. Because it's this balance, right, of wanting to make an impact and also wanting it to be easy and efficient for our clinicians to use.
I think the other thing I would add, Veena, to you really quickly is I think it's also about like the right tool for the right workflow. So one of the things that we heard from other health systems as we looked at implementing a bridge and others was around like the physician toolbox and having the right tools available for the physician in the right workflow, and that it isn't necessarily a one size fits all approach. So I think like Veena's example with surgeons is a great example. They might be using ambient listening for some of their like pre-surgery clinic visits successfully, but then like in the OR, like post-operatively, they might still be using a speech to text fluency dictation tool. And so I know on the digital side, we're always looking for ways to rationalize apps and limit and pare down some of the tools. And we do believe that Ambient will give us the opportunity to do that. But I think it's, again, you have to be thoughtful about, do these tools really do the same thing? Are they going to be used the same way within the workflow? Or is there an opportunity where we should keep both tools for different use cases?
Outstanding. All right, last question here. For our other informatics leaders who are our audience, what pearl of wisdom would you provide to other leaders as they try to deploy this at scale, similar to what Sutter's done? Veena, why don't you go first, and then Stephanie, you can provide your insights as well.
Yeah, I mean, I think first and foremost, it is a tremendous team effort, and bringing the right people to the table from the beginning and collaborating across the organization, has really been critical for us. So the partnership on clinical informatics on my team, with Stephanie's team, with our chief technology officer, right? Just across the board, I think this is all hands on board. You really all need to partake, but putting in that effort can have tremendous returns across the board. So I think really thoughtful and comprehensive implementation strategy is really critical. And, we're seeing organizations doing this every day across the nation. So it's a really, really exciting time.
Stephanie, what are your thoughts? What would you like to leave audience with, and what they should keep in mind on how they could be as successful as Sutter Health?
I think that my top takeaways working with Ambient is really around creating that solid EMR foundation, really preparing Epic or your EMR to be able to quickly adapt to use these tools moving forward, streamlining again and optimizing the workflows. And then I really come back to, I think, Sutter having our digital academy team, having that the effector arm that's really focused on education and clinical adoption is the key to success for us at Sutter in implementing all of our new technology tools, but especially Ambient. And then I think the one focus point, or where I think back to what is some of the hardest work involved in making these changes successful, is around that operational buy-in. Moving to that system-centered approach. And I think Veena hinted at this, but we had such strong support from our senior executive leadership team in just preparing the organization for AI is coming, and that AI is going to help us be successful and set us apart in the future, that we had that foundation. But I wouldn't underestimate the amount of operational change management that's needed. And I think to Veena's point, making sure you have all those key players aligned at the beginning.
Guys, I want to thank you for your insights and guidance. I'm a big fan of Ambient now. I didn't realize the behind the scenes story, but now that I have a semblance in this, I could see how hard it is to implement on an enterprise level, but also the intrinsic value that it provides on multiple levels. Well, I'd like to thank our audience for listening to Beyond the Blueprint. This is Greg Malkery, and I look forward to seeing you next time during our next episode.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.